Hello, and thank you for joining us today. I hope that you're all healthy and safe. Today's discussion will focus on the ways in which COVID-19 has changed our world, as well as the pandemic's longer-term impact on three key areas: health policy, mental health, and global commerce. My name is Sara Bleich. I'm a professor of public health policy at the Harvard T.H. Chan School of Public Health. My work provides evidence to support policies to prevent obesity and diet-related conditions, particularly among high-risk populations. I'm joined today by three of my Harvard colleagues, all of whom are in very high media demand, so we appreciate you taking the time to join us. Michael Barnett is an assistant professor of health policy and research at the Harvard Chan School and a primary care physician. His work focuses on understanding and addressing the inefficient delivery of healthcare in the United States. Karestan Koenen is a professor of psychiatric epidemiology at the Harvard Chan School. Her work aims to reduce the population burden of mental disorders through research, training, and advocacy. Willy Shih is a professor of management practice at Harvard Business School, where he focuses on technology and operations management. I'm going to start off with a few questions for our panelists, and then I'll turn to you for questions. To ask a question, just click on the Q&A in the bottom of the screen. And the first question I want to ask is for all the panelists, and I want to start with Michael. And that is, can you give us a sense of your COVID-19 related research, and then think specifically about in the next 6 months, what is the single most important thing that we can do to have a meaningful impact on the pandemic?
Thanks, Sarah, and thanks for having me and for all the many participants on this call. I appreciate your interest in joining this town hall. So from my perspective, the single most important thing in the next 6 months, it's really testing. I think it's really been in the media. A lot of us are tired of hearing about it, but unless we can actually be able to test really anybody whenever we need to, multiple times, it's not really going to be possible to open the economy, to keep vulnerable populations like nursing homes and prisons and healthcare workers safe. And my particular focus, one of my focuses in the COVID-19 epidemic has been understanding how this pandemic affects vulnerable populations and how nursing homes play a role in both the mortality from the epidemic and their role in potentially spreading disease. And that is a population that really needs to be tested repeatedly and universally. And that's only being done in just a few places at this point.
Thanks, Michael. Karestan.
Thanks, Sarah, and thanks everyone who joined us today. So COVID-19 is a perfect recipe for a mental health crisis. So I'm going to speak up about that. That is, we have uncertainty and unpredictability, which create fear, which is really toxic to mental health. And then you add in job loss, loss of homes, bereavement, and stigma, all of which on their own are toxic to mental health. So, and then on top of that, you have our need to physical distance to stop the pandemic, when we know that social support after a disaster is probably the most important thing we can do to support people's mental health. So it's not surprising that a Kaiser poll recently said that 45% of Americans are concerned about their mental health in this pandemic. And I think that from that point of view, from a mental health point of view, one of the most important things we can do, may be surprising, is help people in terms of their incomes, protect their jobs, and protect their homes. During this time, we know those are major stressors that cause mental health problems, and any sort of efforts to protect people's incomes and homes will really reduce mental health problems, but also enable them to do the things we need to do to stop the pandemic. In terms of my own work, we've been doing two streams of things. One is we've been having mental health forums, and our goal with those forums, they're 11 a.m. on Wednesdays, are to increase resilience in the population by disseminating evidence-based mental health practices just to anyone. They're open to anyone, not just the Harvard community, and not just raising awareness about the problems, but really giving people practical things they can do on solutions. And the other piece is in terms of research. I've been working with colleagues around Harvard, and one of the reasons I love being at Harvard is because I have so many great collaborators. So working with different cohorts, such as the Harvard cohorts, the Nurses' Health Studies, which have big populations of healthcare workers and older adults, and also with Sonia Hernandez-Diaz on her COVID pregnancy registry to incorporate not just measures of COVID infection, but also mental health and positive factors so that we can know how to help specific populations, particularly healthcare workers, older adults, and pregnant women. Thank you.
Thanks. And Willy.
Thank you, Sarah, and thank you all for joining us this morning. My work is mostly on supply chains, and a lot of what I've been doing recently is focusing on resilience and what is the recovery going to look like. I'd like to echo what Michael said earlier, which is I think testing is going to be key. Until people know that we can safely bring them back to work and safely gradually start opening up, it's going to just feed on all of the problems that Karestan mentioned and Michael mentioned as well. So I think testing is absolutely going to be essential. We've seen massive disruptions in the supply chains, and unfortunately, I see that getting worse right now as we see the contagion spreading to the logistics networks and some of the food providers, which is very worrisome to me. So as Michael said earlier, until we can get a grip on testing and understand where we are on that, and here I think, public health and business are very much aligned in terms of objectives where we all need to understand this together.
So Willy, let's stay with you for a minute. Have you been surprised at the flexibility that companies and organizations have shown during this pandemic?
Actually, I've been quite surprised and pleasantly surprised. So for example, I'm actually on the board of a company that manufactures for a lot of other companies, and we're currently engaged in 5 projects to make ventilators for various companies that have come to us. And the CEO was telling me, well, normally, to get through that whole process of putting together a new product and setting up for manufacturing, that's a 2 to 2.5 year process, and they have accomplished that in 6 months. Now, we know that crises have a way of unfreezing kind of the normal assumptions, the normal ways of working. And I'm seeing this more broadly when you see, for example, automakers going into making medical devices, and the number of companies who have started making masks and mask materials and PPE is really gratifying, right? So that's been the surprising thing that's been very good in terms of ability to pivot and really drop all your conventional assumptions about how you do things and move into something that's important.
So switching over to you, Karestan and Michael, both of you have written recently about the hidden pandemics. In your case, Karestan, around mental health. In your case, Michael, around undertreated conditions. So Karestan, let's start with you. Can you tell us whether or not you think that there's going to be a second pandemic related to mental health?
So I think that there's a risk of another pandemic related to mental health because of all the things I mentioned earlier, the uncertainty, unpredictability, and all these additional stressors. What we know from disasters, whether you think of like Hurricane Katrina or the 9/11 terrorist attacks, is that there is, people feel stressed during those when bad things happen and feel anxious and maybe a little hopeless. And that's normal. That's not a mental health problem. But all the additional stressors, like not being able to get a job or not being able to take care of your kids, not having enough food, those are the ones that sort of drive the mental health problems going forward. So I think that as much as we can secure the social safety net and address those ongoing stressors, then we have a chance to avoid a mental health pandemic. The other thing is that's been really promising is Willy mentioned that people during a crisis, it sort of breaks down normal barriers. And I've seen that in mental health. So for example, it's been incredibly challenging to get insurance companies to cover telehealth for mental health problems, either phone sessions or video sessions or video support groups. And within weeks, that has shifted to where sort of every practitioner I know is fully booked. And actually people are coming more regularly because they don't have to leave their homes. So that's actually a positive. Now that doesn't address the people who don't have mental health care, et cetera, which maybe we'll talk about in a bit. But so there's been some positives. There's been a massive amount of dissemination of information about mental health, ours and others. So I think there's a lot of positive things going on that can actually avert a mental health crisis, but there is the potential.
And I'm glad you brought up telemedicine, Karestan, because there's lots of questions right now coming in on that. So we'll come back to it in a little bit. But Michael, turning over to you. So you've written recently in the Washington Post about issues around undertreated illness and how we should be watching out for that. And so from your perspective, How do you think that's going to unfold, and what community should we be particularly worried about?
Thanks, Sarah. So I do think this is going to be a significant challenge. Part of what I wrote about is that office visit volumes have plummeted around the country. Doctors are seeing fewer patients, even with telemedicine and the dramatic increase in the use of telemedicine that we've seen. Almost every practice I've heard from, the drop in their volume is anywhere from 30% to 80%. And so it's not so much that I think that doctors are the ones that are holding the health of the community together by seeing people in the office, but rather I think it represents an overall detachment from healthcare that I think a lot of people are going through. And that can be for many reasons. It can be simply because they're distracted by everything else in their lives, be fear with interacting with the medical establishment because they think it has to be in person. Another thing I frequently encounter is this perception that we are all so busy fighting COVID-19 and with our fire hoses that we can't possibly deal with anybody else's problems, which is actually in a funny way kind of the opposite issue, because many doctors are actually sitting around and not doing very much at all. Another issue, like Karestan was mentioning, is people's mental health is worse. They may be less likely to feel the need or feel motivated to reach out, or they may be unemployed and uninsured, and they're worried about getting charged for a telemedicine visit. So I think all of this adds up to a situation where I think the non-COVID illness, of which there's quite a bit in this country, and which we weren't managing necessarily all that well prior to this, is really going completely on the back burner. And I think people are going to fill their medications less frequently. They're going to be less proactive about taking care of managing their chronic illness. And even more disturbingly, now there's quite a number of reports that emergency departments are actually seeing decreased volumes of things like heart attacks, strokes, appendicitis, things that really shouldn't depend on there being a pandemic or not. But it appears that people are too scared to come to the emergency room, and they're letting problems get much worse than they normally would before they come in. So to me, this all adds up to a situation where I think there's going to be a lot of undertreated illness and pent-up demand once things start to open up. And the healthcare system is going to need even more support than it did before, or rather during COVID-19, to manage all of this and catch up with what we're missing.
So Michael, let's stick with you for a second. A few states have now just begun to allow for elective surgeries. And do you think it makes sense now to let states do this? And what are the implications for controlling COVID-19 now that these elective surgeries are going to start to happen?
It's a bit of a complicated question, in part because the concept of elective surgery is very broad. So, an emergency surgery is something where literally if the surgery does not happen in the next 1 or 2 days, somebody's life or limbs or health will be irrevocably damaged. That's only a small proportion of surgeries, and everything else is basically elective. So part of it depends on how well doctors are really triaging what truly is a necessary elective surgery versus just doing surgeries to keep revenue and volume up. I do think that because healthcare volumes are largely down and healthcare facilities are going to try to be careful, that actually getting an elective surgery may not be quite as high risk as it feels because of how careful hospitals and healthcare facilities are doing. And so my feelings are a little bit mixed about it. I think for the most important elective surgeries, and just to give an example, basically all cancer surgery fits under elective. So to the extent that we do things like, say, restart cancer surgeries or restart surgeries for people with, chronic illnesses that are actually progressing very, kind of inexorably, and they need something. So, somebody who needs thyroid surgery for a disease called Graves' disease. Those are things that I think probably could be reasonable to proceed in a controlled format. But we do have to be careful.
Thanks, Michael. So Willy, now I want to turn to you. And I'm going to ask each of you one more question and then turn to questions from the audience. Lots of them are coming in, so please keep sending them. So Willy, how do you think COVID-related changes in consumer behavior will shape the global economy in the long term?
Well, I think one of the things that this pandemic has done is it's exposed a lot of new ways of working that consumers may not have considered earlier. So, for example, you're seeing a huge uptake in terms of delivery. Okay, you've seen a lot of restaurants pivot to takeout and delivery. we've seen, for example, online education at Harvard and other schools making this massive pivot to online delivery, right? So I think people will say, hey, wait a minute, maybe this wasn't so bad. What can we learn from that? Is it more efficient? Does it make more time for me? So I think, again, having this crisis, a shock that caused everybody to be open to changes and different ways of working, has exposed a lot of possibilities. So, and companies who recognize that and seize on those opportunities, I think can potentially do very, very well. So it's kind of a big unfreezing of our way of working in our daily lives as well.
And Karestan, a last question for you until we turn to the audience questions. Just as people are thinking about things that can be done on an individual basis, how do we think about ways to help people benefit their mental health and well-being during this pandemic?
Well, thanks, Sarah, for asking the question. So a couple of things that people can do is, one is going to sound maybe corny for a panel at Harvard School of Public Health, but is really be kind to yourself and each other, because it's really easy when we're stressed and scared to, it's hard for me to be patient with my son, with my dog, my family, and my neighbors. But we're all going through a hard time. And if we can be kind to each other, that will actually go a long way towards protecting our mental health. The other thing, I'm sure everyone's heard of these things to do, but everyone's told you keep a schedule, eat healthy, et cetera. So not to necessarily repeat those things, but not that they're all not important. But the other thing that can really help us is if we can do something good for someone else. Altruism, there's actually a lot of scientific evidence that altruism improves our own mental health. So if you can think of something you can do for someone else, whether it's someone in your family, your building, your community, that would actually not just help you, but help them and help us get through this.
Thanks. So now I want to turn to your questions. We've had a lot of them come in, and I want to start with testing, which both Michael and Willy started with as sort of the single most important thing that we can do in the next 6 months to try to meaningfully impact the pandemic. And I want to try to address 3 questions. One is why we're so behind. Michael, I'm going to throw that one at you. The second is how do we actually do this globally? Willy, I'm going to throw that one at you. And then once we identify people who are positive, how do we support quarantine individuals? And Michael, I'll ask you to start with that one, and then we'll go to Karestan. So Michael, why don't you start with why we are so behind in testing in the US?
Thanks, Sarah. This is clearly a question that's on a lot of people's minds. And I will begin with a caveat that this is not, I'd say, a core area of my expertise, but it's something that I am following quite closely as our colleagues in our department. But my understanding right now about the holdup in testing is that it's really like a lot of complex problems, multifactorial. There's many different issues combining, and I think Willy is going to have more to add to this as well. But really, it's kind of a cluster of supply chain, leadership, and planning issues. So, for instance, right now, one thing that we're running into is a lot of places are just out of the necessary materials to do testing. And these are things as basic as nasal swabs or chemical reagents that are necessary to do the special PCR test for the swab test, or specific coronavirus testing materials themselves, which was a big problem a few weeks ago. Another issue is the maldistribution of these resources. So there are places that really have much higher demand, much bigger mismatch between supply and demand than others. And there isn't really a very good coordinated state or federal response in many places to really even that out. And that gets to the kind of first problem, which is, we really missed our opportunity to plan for all of this by several weeks because there was a pretty sluggish federal and state response to try to attack this in a coordinated way and really address all the potential supply chain issues ahead of time.
Thanks, Michael. And so, go ahead, Willy. How do we do this globally?
So, and I think Michael raised some key points. One is shortages of, for example, reagents or swabs or things like that. Okay, and also he raised this point of how it's uneven distribution, right? And that's why central coordination in some sense makes sense, because what then you can do is you can pool those shortages and distribute them. Like, somebody may be short of swabs, somebody may be short of reagents, Okay, and it's very unevenly distributed, and that's why you need some kind of coordination. Now, globally, this is my big worry, because for testing, and ultimately when we have some kind of vaccine, which I'm confident we will get to, it's only a question of time, then how do you distribute that fairly? And here you have to think about, it's kind of a global health public good where, we have to worry about poor countries as well, because if this disease is out there as well, right, it's going to come back to us. So we need to step back and not take a nationalistic view on this, but really coordinate globally. So I'm a big advocate of that. The other thing I'll point out, which you say, well, why are these things in short supply? Okay. And one of the questions I've been asked a lot lately is, how could we not be able to make masks? Okay. Now, part of that problem is if you look at how much capacity manufacturers normally put in place, they don't usually have enough surge capacity to handle, I think we've seen a minimum of a 20x leap in demand. Okay. And so if they had that surge capacity come on suddenly, and we're starting to see people add a lot of capacity with new machines and so on, then they would have been penalized in earlier days for having idle capital, having an idle factory. Wall Street analysts would have been all over them if they're a public company. Okay, so that says after we get through this, we really have to rethink what is our strategy for these critical supplies in this kind of emergency.
I'm going to come back to that point, Willy, because there are some follow-up questions that have come through. But before we get there, Michael, I want to turn back to you and think about, let's assume we get testing under control and we identify lots of individuals who need to be quarantined. How do we best help manage and support those groups?
So that's a great question, and one that I think hasn't been explored quite as much as it needs to be. And I think it's important to acknowledge first that people who test positive, of course, at the moment, the best we can do is really use non-pharmaceutical interventions and have them isolate themselves for what we think is 2 weeks being kind of the key period. And most people really don't have the luxury of being able to isolate themselves from their family or work or the community as much as others. I think that's part of the reason why we're seeing, for instance, in Massachusetts, communities like Chelsea or Hyde Park or some of the poorest neighborhoods, in the hotspots, really where COVID-19 is really blazing through at a much faster rate, because there just simply isn't the option to do isolation the same way. So people have raised the idea of some kind of central quarantine. And the idea behind central quarantine is that people who test positive can basically isolate themselves, say in a hotel or something like that. This is a controversial topic. I don't want to necessarily weigh in and say that we need to do it one way or another, but I think it's something that's starting to enter the national conversation more and more. There's just a bipartisan plan that came out this morning led by the former FDA Commissioner Scott Gottlieb and former CMS Commissioner Andy Slavitt, where they actually recommend a voluntary central quarantine as part of a testing strategy. And they also recommend basically paying people for being in central quarantine, kind of akin to a token payment for jury duty. And so I think these are basically some of the strategies that we might have to consider in the kind of hottest spots for COVID-19 to actually be able to act on testing in a way that will be effective. But like I said, it's controversial, and there are potentially alternatives like aggressive contact tracing that may also be effective.
And so, Karestan, from a mental health perspective, how do you think we best help people that are quarantined?
So we actually have research on this in terms of quarantine that's happened in other epidemics like SARS and in Ebola. And a couple of the things we know is that people do better with their mental health in quarantine if they have good information. That's not surprising. If it's predictable, so they know how many days, they know what criteria will be used to release them from quarantine. So that's all laid out for them. If there's any way people can have some control over being given some decision or control over what they bring, et cetera. And then a third thing is as much as you can do to reduce social isolation and keep people connected, although they are physically quarantined. And in terms of that, one of the things I think we need to think about is the digital divide, both for people in quarantine, but also for family members. One of the things that occurs to me is that if quarantine is disproportionately done with people of lower incomes, those may be the same family members who don't have home computers or phones, et cetera, to contact family members in quarantine. So I think that needs to be thought through in terms of how to keep these people socially connected, even if they are in quarantine.
So let's stay with you for a second, Karestan. There are a number of questions that have come in about telemedicine.
Okay.
So, and you sort of alluded to this at the beginning. So the first big picture question is it here to stay? Is this the new normal? And in the case of mental health, is that a good thing? And then Michael, I'm curious to hear your same thoughts from a primary care perspective. But Karestan, let's start with you.
Sure. So the providers I know are saying that it is here to stay, that it's going to be very, very difficult to go back now that they have it. And these are particularly providers who deal with families and kids or parents, people who I know who treat kids or parents or families. It's much easier. Their patients are saying it's, despite everything going on, it's actually much easier to make appointments now that they have telemedicine and they don't have to worry about getting the kids in the car and who's going to watch them and stuff like that. So I think that some of that is here to stay. I actually think anything that makes mental health treatment more accessible is good. So telemedicine may not be for everything in mental health, but I think that there's a lot that can be done via telemedicine or via apps or via Zoom kind of support groups, et cetera. So I do think that is a positive. I think the big challenge is what I mentioned before is we still have this big digital divide in this country. With even in Massachusetts, I think it's almost 20% of kids don't have home computers. Mm-hmm. So the idea that everyone, even if the idea that everyone can engage in telemedicine is false. And it really worries me that so much of what I'm putting out in terms of resources for mental health are online, which is the way I have to put them out, but they probably won't be reaching some of the people that need them the most.
And what do you think, Michael, from a primary care perspective? Is telemedicine the future?
So like Karestan, I do believe that now that the genie is out of the bottle, telemedicine is really here to stay in a really profound way. There are a few different considerations about this. So one is that I think one of the barriers to wider telemedicine adoption prior to COVID-19 is really that doctors were pretty happy and doing well with the current fee-for-service standard payment model and status quo, where basically people cycle to their office and physicians are spending all their time in the exam room just cycling through visits. And that's how they saw patients. And there wasn't really a lot of incentive for them to switch over to telemedicine. And from a patient perspective, most people hadn't really heard of telemedicine or thought of it as really a default standard of care. So now with COVID-19, everybody's had a crash course in what telemedicine is. And at least the doctors and patients I've interacted with within my own practice and also hearing from others is that people have recognized that telemedicine actually, it's not so bad. It's basically, particularly if you know your doctor, seems to work okay. Of course, it's not going to be appropriate for 100% of the issues, and nobody ever pretended that it would be. But I'd say there's probably, it's hard to know the exact percentage, but probably well over half of what primary care doctors do in their standard practice could probably be delivered really without much decrement in quality at all via telemedicine. To Karestan's point about the digital divide, one thing I'd also like to point out is that telemedicine is kind of in some ways a jargon catchphrase, and people think of it as basically the medicine equivalent of what we're doing right now, is having some kind of Zoom meeting. But really, it's not about telemedicine. It's really just about remote care. And a simple telephone call can basically provide you with 90–95% of what you might get done in a telemedicine visit. And so, and then also beyond simply a phone call, sometimes patients can really have their needs met through just a simple patient portal interaction or something called an e-visit, which is like a sort of a templated algorithmic way of doing a visit online. Another thing that doctors can do is send something called an e-consult, where they can basically do a specialty referral for a patient without the patient having to be seen in person and get input on what to do next. So really, there's a wide range of ways that patients and doctors can deliver care that doesn't have to be a live video-to-video visit over a broadband internet connection. So that is, sort of the kind of the most intense type of virtual care that we're able to manage right now. The other variable that I think none of us know exactly what's going to happen is, even though everyone now is used to telemedicine, or at least much more than before, is what are payers going to do, health insurers. are they going to try to scale back on these regulations because they are worried about paying too much once things calm down around COVID-19? My guess is that insurers are going to find it very hard to back off of the loosening telemedicine regulations, because I think a lot of people will be very upset. And insurers don't like to be in the news as being mean people taking things away. So my guess is that if telemedicine regs get pulled back and reimbursement approaches become tighter, it might be in a fairly superficial way. But otherwise, I think the healthcare system has changed from this point, and it's not going to go back to the way it was.
Thanks. Let's switch gears, Willy, and turn to you. Several listeners have raised questions around the supply chain, and they've raised two big picture questions. One is, can you give us some examples of specific supply chain disruptions that you alluded to at the beginning when we first opened up? And the second is, do you think that because of COVID-19, we're going to have a switch from product globalization to local production, even if that means decreased profitability? And then the final piece of it is, in all this, what is the role that either HBS or the School of Public Health can play?
Well, Sarah, when we talk about supply chain disruptions, I really think of it as having several components, or there's several styles of disruption. One, which is very prominent, is when you're reliant on one geographic area for key components. For example, in the supply shock that we initially had during the extended Chinese New Year shutdown in China, a lot of companies found out that they were dependent on components from that. Another supply shock, which is actually heartbreaking when you see it, is things like farmers plowing their crops under, farmers dumping milk because they can't get it to market, when at the same time you see these shortages in the grocery stores, and you say, well, what's going on with that? Okay. And what happened there is it was a question of mix, because there's one set of products that goes towards retail channels, and then there's one set that goes towards institutional channels like hotels, restaurants, schools, institutions that have extended food service. And the packaging is different. Oftentimes, the products themselves are not strictly the same. Okay, so that and that mix difference. I wrote about toilet paper at the beginning of March, and now everybody thinks I'm the world expert on toilet paper. Right? But the thing with toilet paper is, like, once people started hoarding it in the retail channel wasn't prepared for a 3x or 5x jump in demand, because they say, well, toilet paper at home, the usage of that is fairly stable. Okay, but then while they saw this huge increase in demand on the retail side, the consumer side, the institutional side fell off a cliff. Okay, but then one of the manufacturers was telling me, it's like, well, it's not like we can just instantly shift from one to the other. We have to change the packaging, we have to change how we make it, and so on. The third component of that, which has really aggravated a lot of these shortages, even down to testing and PPE and masks and stuff like that, has been the logistics infrastructure, which we tend to take for granted. Okay. But for example, when countries shut down trans-Pacific flights, shut down transatlantic flights, we don't appreciate that more than 50% of air cargo flies in the bellies of passenger planes, right? So now when you're trying to get PPE out of China, the ocean carriers have canceled a lot of sailings because there's no demand for furniture and household goods and things like that. Meanwhile, air cargo yesterday hit an all-time high in terms of how much it costs to ship a kilogram from Shanghai to Europe, or Pearl River Delta to the United States, right? So all of those things, have made for a very complex and very difficult mix of problems all happening at the same time.
And then the other piece of that question was the shift from local production to...
Yeah, local production. Well, that's what we are hearing a lot of right now. I'm getting a lot of calls from Washington, like from various staff offices, talking about more resilience in manufacturing, and we want to reshore things so that we're not dependent on these distant sources of supply. It's going to depend how well we learn our lessons, because the supply chain structure that we have today is driven by delivering, a cornucopia of products at low cost. Okay, and the question is, are we willing to pay more for PPE made in the US. I would think we would be, okay? But when it gets down to the pressure on healthcare costs or the pressure on the consumer presented with a product that is imported or one that is local, are we willing to pay for that resiliency? I worry about that because I'm not sure that we are.
Thanks. So let's switch gears now and talk a little bit about inequality, which came up a bit from Michael and Karestan, and several people in the audience have asked questions about this. So I'm going to frame this in terms of the broader social determinants of health, which are ideas, things like poverty and transportation and education, things that have become a large part of the national discussion during this pandemic. And so one question is, what can we learn from this experience about how do we address social determinants of health going forward in times of pandemic, and specifically with respect to both behavioral health services? Karestan, there was a question directed at you, and Michael, in the healthcare system, how do we help vulnerable populations not fall through the cracks? And Karestan, why don't we start with you?
Thank you, Sarah. Thanks for the people who brought up these questions. That's something I've been thinking about a lot. So all the things you mentioned, also poverty and food insecurity, are also major determinants of mental health problems. And so they are something that the mental health system has struggled with for a long time, including absence of mental health parity, and even among those who have insurance. Anyone who's tried to get insured mental health care, even in places like Massachusetts, it's really challenging. So one potentially positive thing that's come out of COVID is, as Michael had said, is it's really forced people to rethink how they deliver mental health care, which has been basically relied on either pharmaceutical prescriptions, which are only so effective, or mainly the evidence-based treatments or interaction between a single provider and a single person in an office, maybe on a video. But even sort of telephone or other kinds of measures have not been that well studied. There's some evidence with apps and things like that. So I think it's really pushed mental health to think outside the box. And I think this has a lot of potential for addressing some of the inequalities in mental health care. So my colleagues who work in global mental health have used a lot of different systems which have evidence to improve mental health in hard to reach populations, such as training leaders in the community in mental health, going outside the system in terms of having community mental health workers, but they're not necessarily people in healthcare. They are people who are recognized, like I said, leaders in the community, or recognized leaders by, say, in a community, like for churches, trained in mental health and being able to deliver it to peers, peer-on-peer mental health services. So I think that that this has, the inequalities that have been highlighted by this have really offered the potential to go in maybe some of those directions, which in my experience in the US, we've been really resistant to, but have been successful in other places.
And Karestan, are there specific policies you think might be particularly effective?
That is a good question. As a non-policy, I'm not a policy, as a non-policy expert. But I think that policies, I said before, I think economic policies that protect people's homes, jobs, and food availability actually are ways of preventing mental health problems. And then policies, again, this is really outside my wheelhouse, but ways that we can enable and actually get funded people in the community workers, peers, to provide mental health support to people in the community. That it's not always by a provider like a psychologist like me or a physician. I don't know how that works in the kind of health system we have, but anything that would support that, I think would be really important going forward.
And Michael, how about on the primary care setting? How do we help address inequalities and social determinants of health?
Yeah, so the striking inequality, particularly along racial lines and poverty, has been really quite clear as the data has come out around COVID-19. I don't think that really what we're facing right now highlights that we need to do things differently than solutions that have been raised before. I think really COVID-19 has highlighted disparities that researchers and community advocates have been talking about for ages, which is that really we need to invest more in our safety net, in taking care of vulnerable populations, and doing things that aren't necessarily sound all that revolutionary, but we haven't really seemed to muster the political will to really take care of them in this country. So things like expanding Medicaid in states that have not expanded Medicaid yet. Things like trying to bolster Medicaid budgets so that Medicaid actually has more resources to be able to support healthcare systems and patients who need that. So for instance, Boston Medical Center is the safety net hospital in the Boston region. And even though they only have about 3% of the beds in the state, I've heard from doctors there that they have anywhere from 15 to 20% of the COVID-19 patients in the state. And so, and they are perennially kind of on the verge of bankruptcy or financial insolvency. They are the safety net provider for the state, and they are beholden to how we invest in our Medicaid system. Another example, I think telemedicine is great, but as Karestan mentioned, it's only going to be helpful for reducing disparities if we actually can give people access to the technology necessary to engage in it properly. So the other example I was going to bring up is another vulnerable population I've brought up a few times now is nursing homes and older adults, the elderly, who are being cared for in long-term care settings, including at home. Those are also settings that we underinvest in. One of the reasons that nursing homes have been suffering so much is because they are also not paid very well. Medicaid, again, is the culprit there, really. They have staff that are paid minimum wage, and there's a lot of staff turnover, and it's very hard for them to have the resources to train around infection control and get personal protective equipment for PPE and get the resources they need to manage and prevent these infections. Underinvestment in nursing homes has really been a chronic issue for decades, and advocates have been talking about the coming crisis in long-term care and our nursing home infrastructure for a long time. What COVID-19 has done is it's really forced us to face all of these immediately and very dramatically.
And another thing that's come up that's also related to low-income populations and vulnerable groups is this idea of, should we push towards herd immunity? And so I don't expect you to sort of unpack that entire issue, but do you think that it has particular implications, Michael, for low-income or vulnerable populations?
Yeah, so the herd immunity concept has been brought up a lot. And I think, now speaking as a non-epidemiologist, but really as a physician that has a working knowledge of epidemiology and thinking about this from a health system perspective, the idea is that, COVID-19 is going to become less of a problem as more of the population becomes immune. And that can happen either because people get sick with COVID-19 or you vaccinate them. And the idea of developing herd immunity is, it's easy to see why it's tempting, since it feels inevitable that people might get infected one way or another. But I think it's important to realize that our healthcare systems in local areas have been overwhelmed with only a small portion of the population actually getting sick with COVID-19. And the antibody studies that we're doing to figure out the percent of population that are sick, they're kind of all over the place. And I think there's still a lot of controversy as to what percentage of the population in different areas really have actually contracted COVID. But let's say 10% is probably kind of on the high side of what experts estimate in a variety of regions. So everything we faced up to this point is still only a small minority of people, ranging anywhere from 5% to 20%, who knows the exact number. And so really, the longer that we can wait this out, the more likely we are to be closer to a vaccine, to have effective treatments, and for the population to be able to withstand this better. But we also have to balance that against the economic damage. But the idea that somehow just unleashing this on the population is going to solve things quicker is, I think, likely to lead to a humanitarian and economic catastrophe, because we've only seen a tiny fraction of the havoc that COVID-19 can cause.
And if we wait this out, we'll be wearing masks for a long time. And so, Karestan, a question to you is, are there psychological impacts to us having social interactions with masks on?
That is a really good question. I think that, so there are, in the sense that we interact a lot by our facial expressions beyond our words, right? So even if you're speaking, we actually judge a lot about other people, and we infer a lot by how they look and their especially their mouth and stuff. We can still see people's eyes, right? So I think there are psychological impacts, although of course the benefit at this point I believe outweighs those impacts. And I also think we'll adapt and learn new ways of interacting and relating to each other with masks on, just like we're learning how to do that via video or doing more phone calls, et cetera.
So if we then move away from the individual and think globally, Willy, I want to turn back to you and think more broadly about this issue of globalization versus things becoming more local. And so the question is, how fully can we retreat from globalization? And are there certain things that are going to drive us in one direction or another? And you've already talked about some of those challenges.
Well, I think there's going to be a desire to be more resilient, okay, to have more control of our own fate in supply chains, okay, but I think people are kind of underestimating the difficulty associated with that. We look at, our dependency on China. A lot of that has been because of low-cost manufacture. China is reasonably self-sufficient on that, but in order to capture those supply chains, that was a process that I would say took 15 years. For example, in the field of electronics and a lot of consumer products, it took them 15 years to get to the point where they had the majority of the supply chain, and they still don't have all of it. Okay, so if we wanted to do that, I think it will take a concerted effort. The question you will have to ask is, how do you feel not only about having a higher cost local source of supply, but then one that, because you tolerate higher costs through either paying more or tariffs or something like that, how do you feel about having a supplier who is not globally competitive? Okay, so I'm relatively skeptical about that. One of the things I'm advocating for is, if we want to have more resilience, we need to think about having multiple sourcing strategies, and we might want to say, how do we think about it regionally? For example, North America as a region rather than the United States per se, because that gives you more diversity as well, or even better, if, between North America and Europe, we say we want to have more resilience, we want to have multiple sources of supply. It's a problem that I think a lot of people underestimate, because in today's world, with all the complexity of technology, you are forced by nature to do a lot of specialization. So that means you have a lot of these niche suppliers, specialty suppliers who make PCR reagents, for example, and there aren't a lot of them because some of the processes are fairly complex, right? So I'm skeptical that, when push comes to shove, we really want to back away from globalization. The other thing I would say about that is, one thing that this pandemic has shown, especially in the global alliance among scientists everywhere in terms of efforts for treatments and vaccines and so on, that's been one of the things that I think highlights the benefit of globalization and global knowledge sharing, right? So I hope that we don't, decide that we have to beat a retreat from that, because I don't think we're better off if we do it.
Thank you. So I want to switch gears a little bit and talk about costs. And Michael, this question is for you. Hospitals and doctors' offices are taking a huge financial hit. When we started off, you mentioned that anecdotally, offices might be down 30% to 80% in their volume. And so my question is, what does this mean for the future of health systems going forward?
Thanks, Sarah. I think this is a very important topic, and one of the larger changes that might come out of the coronavirus pandemic for the healthcare community. So the problem is that even though in some ways health systems are extremely busy managing the surge of COVID-19 patients, hospitals and medical clinics have canceled basically every routine appointment, all elective surgeries, and are largely proceeding with urgent or necessary visits. And clinics have transitioned to telemedicine, but it seems that telemedicine volumes are not really meeting their normal volumes much at all. And in the current landscape, telemedicine visits don't reimburse at the same level for the same amount of time as office visits. So what that means is that the healthcare system is losing revenue hand over fist, hospitals and small practices. What I think this means, and we've already seen evidence of this, is that practices are going to go bankrupt. There are already massive layoffs happening. of the 22 million plus, 26 million plus unemployment insurance claims that have gone in the past month or so. In every report, the Department of Labor is citing the healthcare industry as one of the most prominent sources of loss. And what are the implications of this for the future? I think one of the implications is that smaller practices, smaller hospitals are going to go out of business. And what's going to happen to them is that larger systems and for-profit organizations are going to buy them up. And it's going to further accelerate the process of consolidation in our healthcare system. And if there's one thing that we know about consolidation in the healthcare system, it's that it drives prices up. Because the larger a healthcare organization is, then the higher the price that they can negotiate with insurers in the area. And so that actually drives one, simply because of basically monopoly power among health systems. Another implication is that the smaller, more financially vulnerable healthcare institutions, again, are those that serve vulnerable populations. This is going to be especially true in rural areas, and also going to be true in areas that maybe aren't as rural, but that serve that serve more socioeconomically depressed, vulnerable populations. Namely, again, this theme coming up, healthcare organizations that serve people on Medicaid. So really, we could see an acceleration of healthcare facilities that serve the most vulnerable going out of business, and other smaller organizations just simply consolidating into larger groups, potentially accelerating the problem of healthcare costs that we were facing and discussing every single day prior to COVID-19.
And Willy, from a supply chain perspective, what are your thoughts on the huge financial toll and companies going out of business in terms of the disruption that we might see?
Well, I think especially some of the smaller companies, it's going to be a terrible disruption because we have this complex network. And if you're putting together a car or if you're putting together some other product, you only need that one small supplier to go out of business. A lot of these small businesses really run on a cash basis, right? And so the cash crunch has been severe for them, okay? But I think the other thing that we are seeing, as I said, is this ability to pivot and move on to different things. So I'm hopeful in that regard. I think we are going to see a lot of questions about, for example, with the trade war, we had already gone to, a lot of companies were thinking about, well, I need to have China plus one. Okay, so maybe I'll manufacture in China and Vietnam. Okay, but now people are saying even that's not going to be good enough. Maybe I need to think about China plus 4 or 5, right? So maybe I go to Vietnam, Mexico, Sri Lanka, a couple other places for my sources of supply. That has implications for logistics, it has implications for efficiency. It's going to take a long time to sort this mess out.
And so, Karestan, if we sort of switch gears now and think about developing countries and mental health issues, and we've talked already about issues around quarantine, how do you think about whether or not these issues are going to be more acutely felt in developing countries, issues related to social isolation, the need for people to quarantine when they're positive, or even access to mental health services in general?
So we had a panel with our colleagues from Africa who spoke about this, and there's the potential for it all to be worse in terms of, we already know, if we look at only half the people with a diagnosed mental disorder in the US get mental health care, it's 5 or 10% in most low-income countries. So there's fewer services and there is less access. And the other issues are, in terms of quarantine, the conditions where it's being put into place, the conditions of quarantine are very, very physically difficult. So it's not, quarantine at a hotel or at, hotel when any of us would want to stay at. So I think those are all huge challenges. I think on the positive side that there's been a lot of work by WHO and colleagues in global mental health that have done work at the community level to improve access to mental health care beyond the traditional healthcare system. So I think that is the positive. But I think that our colleagues are seeing things being worse. And a lot of my colleagues who are psychiatrists in these settings are getting pulled into COVID care because there's so few trained physicians. So that even people who have mental health training might be getting pulled into caring for COVID patients. So many challenges.
So we're getting close to closing, and because we've talked about a lot of, I won't say depressing, but issues related to sort of where we go with COVID-19, it's scary, frankly, about where we are now and where we're going. And so I'd like to wrap this session with a little bit of optimism. And I'd like for you to think about, despite the fact that there's been a massive human toll, there's been a massive economic toll, can you think of any silver linings that we can look to for hope with respect to this pandemic? And Karestan, let's start with you.
Yeah, in terms of mental health, I see a few silver linings. One is reduction in stigma. It seems like everyone's talking about mental health. The second is global collaboration. This is the first time there's been a major disaster that affects all the places where I work at one time. And so the amount of, Willy mentioned this, the amount of collaboration, sharing what different communities are doing and trying, and then the innovation that comes out of that. People are really trying to think outside the box and pivot and think about how to address these issues. And it sort of let down a number of barriers in the mental health system that really would have taken, I'm not sure they ever would have changed without this crisis. So I see all that as positives. And then just to close with that, I think people need to remember that human beings are incredibly resilient. Having been through, anyone who's on this call, I'm sure if you're here, you're a survivor. If you're still, if you're a human being, you've been through many difficult things, and you will get through this. We will get through this. We will transform it. But it will take time and flexibility and some persistence.
Willy, how about you?
Well, as we were talking, as Karestan just said, I think one of the things that we have seen is the benefits of connectedness, of international collaboration, and this is not only across countries, but even firms, partnering with people who they never would have partnered before. So I think on the one hand, that's really positive. On the other hand, I talk to students about this a lot in terms of being forged in crisis, right? And, what is crisis, right? It's, a turning point for better or for worse. I think we will get better. We know we will get better. Okay. And what's forging? Forging is all about, if you were a metallurgist, forging is all about, I'm going to strengthen this. And so I see a lot of people, I see organizations, being forged in crisis, finding out that they're capable of things that they never imagined they were capable of before. And I think that's really very optimistic and very gratifying.
And Michael will give you the final word. Thank you, Sara. And thank you, everybody, for joining us. This is a really great discussion today. My thought, from a healthcare system perspective is that I hope that COVID-19 really is a jolt to the healthcare system to think about how we can deliver care differently than the status quo. And a number of audience members have asked about reimbursement. I also hope this is going to be an impetus for us to also reconsider how do we pay the healthcare system, because clearly we are not resilient enough to withstand a shock of this magnitude under the current model. And so to the extent that this really gets providers and patients to think about how can we deliver care outside of the inefficient way of everybody coming to an office and thinking more from a population health, public health perspective, and bringing healthcare delivery and public health closer together. Those are things that I think are going to emerge much stronger because of this crisis, and I hope we can keep going with.
Thank you. Well, I want to thank Michael and Karestan and Willy for their time and for their insights. I agree, this has been a really nice discussion. For those of you who are in the audience, you'll be receiving a follow-up email from Harvard Chan School describing ways you can stay up to date on our urgent COVID-related work, including future town hall discussions like this one. And you can always read more on the school's website at hsbh.harvard.edu. In the meantime, I hope that you all take care and stay safe. Thank you.